Hello everyone, welcome to this introduction to the EGLS course. If you're listening to this, we'll hopefully meet you sometime soon. Let's start by looking at why we would even need ultrasound to evaluate a patient in shock. Well, we've all seen patients like this one, where we don't really have a history. The physical doesn't send us in any one specific direction. This guy could have just about anything. He could have a PE, an MI, a tamponade, he could be septic or have an occult bleed. Fortunately, we're often able to narrow the differential a bit more, but it's in cases like this one where having an extra tool can make all the difference. Now, ultrasound shouldn't change our practice completely, except maybe when we unexpectedly find a tamponade, but it will help us have a narrower differential, a better working diagnosis, and get there faster. In addition to enhancing the quality of our evaluation, it will help us feel more comfortable as clinicians. For every patient in shock we see, we can get to a point where we're kind of getting out of our comfort zone. This will happen faster with older, sicker patients. And we'll get to a point where we have to look at a somewhat skeptical nurse and tell her, yeah, give him another liter of fluids. No, he won't be in pulmonary edema. And when it's not clinically evident anymore to say if our patient is still fluid responsive or not, he'll often be moved to the ICU, where monitoring tools will help the intensivist evaluate the patient's hemodynamic state. But ultrasound is a great portable monitoring tool. We can assess preload, cardiac function, and the lungs. So getting back to our case and why we should use ultrasound in shock, would you be scared of giving this patient more fluids, even if he's known for cardiac insufficiency? Well, his heart is certainly pumping well today, and his IVC completely collapses. He's completely empty. Ultrasound, in this case, helped us to confirm that this patient is highly likely to be fluid responsive and feel more comfortable in doing so. Maybe the thought that's crossing your mind is, why would we even need an algorithm to use ultrasound in this context? Well, whatever we do, we can't get around the fact that ultrasound is an operator-dependent modality. A good bedside sonographer obviously needs to be able to generate reasonably good images in a somewhat short amount of time. He also needs to be able to interpret these images and make good use of this information in light of the clinical context. So the basic skill set not only comprises image acquisition, but also image interpretation and integration. Probably the best illustration of this is ACLS, that has been, since the 70s, the standard of care in the management of ARES patients worldwide. And the advantage of an algorithmic approach in this context goes without saying. But a patient in shock comes from exactly the same population as those from the PEA branch of ACLS. We only get to see them 30 minutes earlier. So in the EGLS course, we'll see lung ultrasound, then echo, focused echo. First off, the subcostal area, subcostal view itself, the IVC, and then go over the thorax for the parasternal long and short axis view and the apical four-chamber view. We'll put it all together in a manner that helps us to categorize shock and initiate the proper treatment. One of the main challenges of ultrasound is getting a sense of our spatial orientation, of what we're looking at. The images on the screen are 2D images of an organ that has 3 dimensions somewhere in the body of the patient. So if I were to ask you what part of the patient is screen right, well, it's the left part of the patient. If you're not sure, you can use the screen marker that corresponds to the marker on the probe. And the marker on the probe in this example, in the subxiphoid view, is oriented towards the left of the patient. So we can say that this part of the screen, the right side, is the left part of the patient. In ultrasound nomenclature, the top part of the screen is called near field and the bottom part is called far field. That's because it represents structures that are either near or far from the probe. It's a bit like if the probe was on top of the screen, projecting the image. So everything that's close to the probe will be in the top of the screen, and what's far from the probe will be in the bottom of the screen. So let's turn the image in the top right corner so that the probe orientation fit. And we see that the near field corresponds to the feet of the patient, whereas far field in this example of an apical 4-chamber view corresponds to the head of the patient. Now for M mode. M stands for motion. M mode gives us an idea of motion represented against a time interval. So if we imagine a small blue object going slowly up before descending somewhat faster, we would get a diagram like this one. In M mode, the ultrasound system will only interrogate structures on one thin line, the line that's right here. It will not take into account what's going on here or there. So the first thing to do is put a cursor on the structure we want to interrogate, in this case the IVC. Then by pressing the M mode button once again, we will get an image like this one, where we have the IVC in black right there. And we said the IVC collapses upon inspiration. And seeing an image like that one gives us a sense of what's going on with the IVC when the patient breathes. It's a bit like seeing an IVC in transverse that's completely full, then collapses upon inspiration before re-expanding to its original shape as the patient exhales. Up to now, we haven't spoken about Doppler. While many Doppler applications can give us interesting information about our shock patient, reliable results are harder to get and require more advanced training. So for today, we won't speak about Doppler and we'll stick to 2D imaging and M mode. For the purposes of EGLS, we'll be using 3 types of probes. We have our low frequency probes here on the left. So we have the phased array or cardiac probe, the curvilinear or abdominal probe right here. Both of these have low frequency. That means they can see deep in the body of the patient, but they don't have that good a resolution. Whereas our high frequency probe, the linear probe, doesn't have a good penetration. It cannot see deep in the patient, but it does have sharper images. So for all our indications, all of them can be done with low frequency probes, whether it be echo, subcostal view, lung, IVC, even lung sliding. But lung sliding will be better seen with the high frequency probe. While the focus of the course is not on artifacts, let's go over some of them so we make sure we interpret the images appropriately. If we don't have enough gel, we'll lose part of the screen in which it will be impossible to see any organized image, since the ultrasound beam has been dispersed by air between the transducer, and the patient's skin. Whenever we have a hard time obtaining images, make sure you have enough gel under your probe. Now we can get dispersion from air in the gastric bubble, like here, where we see the right part of the screen is amputated by dispersion, or like in this example, where a bigger part of the heart is not seen because of the gastric bubble. Now, whenever we have a bone, we will have shadow in its far field. They tend to be linear, and since the bone blocks all of the ultrasound beam, we cannot see what's going on behind them. They will stay black on the screen. Now let's take a couple of examples from the abdomen. Because there's less structure, it's easier to see the artifacts themselves. Here we have aorta and IVC. And these 2 black lines are refraction. Refraction occurs in these 2 areas because the beam that travels here travels in a linear fashion, whereas the beam that hits fluids will be deviated from its course. So no beam actually comes to this area and this one. They stay black on the screen. Now, do you see another artifact in this image? That's right, there's shadow behind the vertebral body. And here we have, once again, refraction seen in this apical 4-chamber view right here, where we can also appreciate a pericardial effusion. This is the bladder. We're in the pelvis, so bladder right here. And in the posterior part, in the far field of the bladder, we see it's brighter, it's whiter. This is because fluid helps ultrasound beam to travel easier. So it will always appear brighter behind a fluid filled structure than on its surroundings. You can see the same thing here in personal short axis view, where the far field of the heart tends to be wider. And finally, here we go to the pelvis in the longitudinal view. So we have the bladder right here. And left of this line, there's absolutely no structured image because of bowel gas that disperses the ultrasound beam. We see refraction or edge artifact on the edges of the structure containing fluid and enhancement in the far field of the bladder. Here's a view you should be able to see from time to time doing a personal long axis view. Of course, that's if you follow our advice of starting deep and then decreasing depth to concentrate on the heart itself after making sure there's no pericardial or pleural effusions. This patient probably doesn't have two hearts. It's a mirror image. It's an artifact. It doesn't exist for real. Artifacts are interpretation errors done by the machine. They sometimes disappear when we play with the settings or if we change our probe position, if that's an option. But most of the time we're kind of stuck with them. So we have to subtract them from the interpretation we'll be doing of what's on the screen. Now remember that what we want to do with ultrasound is use it in the clinical context. So always keep that in mind when we'll come to the course.